Hi, this is Chris Shocker with Clinical Data Management Systems and Visor Health. I'm going to talk to you today about some work we recently completed with the Iowa Primary Care Association and the Iowa Health Collaborative to help ambulatory clinics gain a better understanding of their patient populations using the PREPARE assessment. First, a little bit about my background. I've spent my entire career in healthcare. First working on clinical, translational, and behavioral research, then developing analytic systems and performing analyses related to operations, finance, and strategic decision-making in the hospital and ambulatory world. I also have a deep understanding of Medicaid data, having led the team that provides analytic support to the state of Wisconsin. More recently, I've spent a significant amount of my time thinking about how to measure clinical quality and provide support to primary care providers managing chronic disease populations. Now I spend all my time focused on our two companies, Clinical Data Management Systems and Visor Health. We specialize in creating and supporting data management and reporting systems, as well as the analysis of healthcare data. So let's get started and talk about the big challenge of healthcare. It's been widely noted that what we generally think of as health outcomes, that is our ability to participate fully in everyday activities of life, how many resources are required to keep us functioning, even our mortality, are significantly impacted by the things we do individually to take care of ourselves or to cause ourselves harm. Smoking, drinking, eating too much, not exercising, and the like have a significant impact on what we generally think of as our health. 20% of the variance in those health outcomes are the result of social and environmental factors, and about 30% is the result of genetics. That leaves only 10% of the variance in our health outcomes that can be influenced by the health care we receive. Yet, in the eyes of patients, payers, really everyone in our society, primary care doctors, and the health system more broadly, are seen as the responsible party. That's a huge lift when you only have this small influence on outcomes. In fact, if we think more closely about this problem, we see that 60% of the variance in health outcomes is driven by social and behavioral factors. We've come to refer to these underlying factors as a group as social determinants of health, or perhaps more appropriately, the social drivers of health. The Kaiser Family Foundation organizes these social determinants or these social drivers of health into 6 categories. The first, economic stability. This has a lot to do with what other types of insecurities that you'll suffer if you don't have employment, you don't have an income, or you have other overwhelming debt or medical bills that detract from your ability to seek and pay for adequate food, housing, and the like. Your neighborhood and physical environment. Do you have housing? Is it reliable and safe? Do you have transportation in your neighborhood? Education, literacy, language skills, and more generally, your education level play a vital role in being able to not only seek and obtain employment, but to navigate the healthcare system itself. Food. Do you have food insecurity? Again, this can often be related to income, but also geographically, do you have access to healthy options for food where you live? Community and social context. Do you feel a sense of social integration? Are there stresses on your life? Do you suffer from discrimination? All of these things make it harder to just live your life day to day, and that often will come to impact your health. And the healthcare system to which you have access. Do you have health coverage? Do you have good availability to providers? And do you have good availability to providers that offer high quality care? All of these things impact in a very complex way everything we think of as a definition of health outcomes: mortality, morbidity, resources expended on your health, and your functional limitations. Thanks to the National Association of Community Health Centers, a well-validated, reliable measurement instrument has been created to collect data within the ambulatory clinic on many of these social determinants. Further, NAC has worked with many EMR providers to build this content into their systems so that providers within the context of a clinic visit can capture information about socioeconomic class, resources, and the psychosocial factors that are considered among some of the most important social drivers of health. Certainly within the other areas of your EMR practice management system, you're able to capture many of these social determinants, be it an income level, an employment status. The problem becomes that many of these things are captured in a variety of different tables within the database underlying your EMR. And so you get a problem like this, where you've done a good job of capturing all of these different data elements, but the way they're organized makes it very difficult for you to analyze the data and report on it. And ultimately, what ambulatory centers want to do with these data to help impact outcomes is to provide the types of supportive services that are required in order to meet the needs of their patient population. But it's difficult to do, like I said, when the data are just poorly organized for that purpose. In many EMR systems, you're capturing observations of data, and those observations may not be arranged in a manner that's conducive to further analysis and reporting. So you end up with data sets like this, where you do have for a given visit all of those data elements that you've captured, but they're not really organized in a user-friendly fashion. So one of the things that we've helped the Iowa Primary Care Association do is make a new data model that captures those data in the native EMR format and transforms them into analytic data sets. We've gone back through the EMR and identified all of those different questions from Prepare and what data element they link to in the EMR. In this case, we're looking at the Centricity EMR, and this is content provided by the Alliance of Chicago. And we're able, again, to take that data set that maybe isn't very conducive to analysis and reporting, transform that data, and create a new data set. These data sets, in turn, are loaded into a multi-tenant database that allows the Iowa Primary Care Association and the Health Center Control Network to see the data in aggregate from all of the centers running the Virence Centricity EMR in one place, while at the same time keeping the data segregated so that each of the health centers sees only their patient-level data. On top of that data platform has been installed a Tableau server. And Tableau allows for visualizations of aggregated data across the network, and then more granular data to be provided at the patient level for the individual health centers, who can in turn use these data to identify cohorts of patients with similar needs, to study the need profiles of their patient population so that they can provide the appropriate resources in a prioritized manner, and to look at trends over time in their patient population, as well as the relationship among these different drivers of health. And of course, this can also be used, now that the data is in an analytical data set, to produce risk scores and predictive models for total cost of care, resource utilization, and operational performance and care management activities at the individual centers. They've created a few performance measures so far, the most important being probably the number or proportion of patients in a given cohort that have had a prepare assessment in the last 12 months, with the goal of really capturing all of these social determinants of health data points. This data platform is part of an overall analytics strategy for Iowa Primary Care Association that includes some specialized computing and analysis resources. The Tableau and SQL Server environment have been built such that there is a standalone Tableau server and a standalone SQL server in both a development environment and in a production environment, with the idea being that as new solutions are built, they're built in the development environment and then migrated to the production environment where the rest of the end users, both at the health center and at the Primary Care Association, can access those data. The project's really wrapped up with the preparation of documentation that outlines all of the details of the data structure from the Virent Centricity EMR forms and how those data are transformed into the analytic data sets that exist on SQL Server, as well as an administrative handbook that will be turned over to the Iowa Primary Care Association as they get the handoff of the system and start running it on a daily basis. Now that we've discussed how the data are captured in the EMR during the clinic visit, extracted from the EMR and transformed into the SQL Server database, we'll take a look at the Tableau visualizations. These are some of the early visualizations that we've been working on. A number of new ones have made it into the production environment since this time, and additional ones, of course, are planned in the future. In this first Tableau dashboard, we see the total numbers of patients assessed using Prepare at the health center is 13,508. We also have a listing of the providers at the health center with a horizontal bar chart of the number of assessments that have been performed on patients in their panel. In the upper right, we see a rolling 16-month trend of the number of assessments performed, and in the lower right, we see a bubble chart representing the relative number of patients in each of the 6 social determinants risk strata. This is a very early draft of the Prepare Overview dashboard, which has since become more sophisticated and includes an updated risk scoring algorithm for social determinants of health with a scale that ranges from 0 to 46. This more detailed scale helps differentiate patient panels more precisely, which is helpful because one of the things that can be done with Tableau is to make workbooks and dashboards more interactive. As you can see by clicking on the bar for David Rasmussen, selecting the bar has the effect of filtering the other visualizations to show only his number of assessments in the rolling vertical bar chart, and the risk score distribution reflects his specific patient panel. This becomes even more apparent when using the latest revised risk scoring algorithm, but this interactive graph allows the health center to understand the provider panel burden in a whole new way. In addition to traditional measures of clinical risk score panel burden, now organizations can understand their patient panels in a whole new way. This interactive capability can be used to gain insight into the relationship between other social determinants. For example, in the 18 to 24-year-old age group, members are almost twice as likely to be high school graduates as those in the 40 to 49-year-old age group. Family size and educational attainment are also linked in a very easily detected manner, with only 1.5% of those with a family size of 6 having a college degree, compared to 10% of those with a family size of 3. The Resources dashboard is where you can see the most granular data relating to the impact of individual social drivers of health, with 9.5% of patients screened responding positively that they often do not have enough food, more than 10% reporting that they have trouble paying for health care costs, and more than 10% responding that lack of transportation was an issue for them. Also note that more than 43% of the respondents identified that they were unemployed. In reviewing one final dashboard, we map the birth countries of the assessed individuals and find that over 30% of patients assessed at this health center were born in South and Central America. I think most health centers have an anecdotal sense of the proportion of patients born in other countries, but having hard data may provide a more solid foundation for decision making around things like the types of interpreters needed and the need for certain targeted cultural education programs. To conclude, I would like to say that extracting these data from the EMR using an automated nightly process and presenting them in a rich visualization platform has provided a lens into the data that was not previously available. The next generation of these solutions should take the next logical step to linking individual patient risk profiles to information on available community resources, incorporate a clinical risk score with a social determinants risk score, and integrate these data points with care management solutions that empower caseworkers to more effectively identify and prioritize the risks these factors pose to the health of their patients. Further, including these variables in a risk adjustment model predictive of the total cost of care will allow us to see the magnitude of many of these social drivers over and above the clinical risk. If you have questions about this project, please feel free to contact me by email, on Twitter, or LinkedIn.